Today's discussion will be on a topic which is sometimes much more common than we would like to accept it. It's called multiple traumas involving either motor vehicle accidents or from falls or any other gunshot wounds, etc. Over the last 72 hours, I was involved in a very, very close relative of mine who was involved in a motor vehicle accident. It was, in fact, a very surreal thing that she was at a gas station just pumping her gas when two cars collided from another location and actually pinned her, went over the guardrail and actually pinned her against the gas pump when she was pumping gas at the back of a car. My only reason for telling you this is that basically the way accidents happen, none of us can predict. And unfortunate for her that she was pinned with quite a tremendous amount of force. This dear relative of mine is alive and well, but the last 48 to 72 hours were very, very serious situations to deal with. And as such, I will try and explain to you some of the situations that occur or some of the things you can actually be aware of that could occur immediately after severe multiple trauma injuries, as happened in the case of this dear cousin of mine. The issue with that is if you are made aware of it, at least you can be able to ask your doctors the pertinent questions, especially when you're there in the state of worry and anxiety and not quite sure what the eventual prognosis is going to be. In the case of my cousin Esther, the issue here was basically she sustained injuries to the head, to the neck, to the ribs, to the pelvic bones, and multiple soft tissue injury involving the legs. So much so that she lost consciousness and evidence of cerebral edema. But let me generalize this to the average patient who's involved in an incident, whether it be a fall from a height or involved in a motor vehicle accident or any other trauma in which result in multiple injuries. Multiple injuries is basically injuries that occur in more than one body area. If we look at the mannequin, for instance, in her case, she had trauma to the head, having been pinned against a gas pump by a motor vehicle, and the impact force of it actually caused cerebral edema. You imagine that there's an accelerating and a decelerating injury when you actually get a severe blunt trauma with a hit to the head. You will get bleeding within. Small bleedings to give you enough of a headache, so much so you can get post-concussion headaches. Imagine being hit by a motor vehicle with an impact force of 30 miles per hour against something that is still, the impact force created actually causes a jarring of the meninges of the brain and could actually cause bleeding. It can result in much more sinister bleeding in terms of things like subarachnoid hemorrhages, subdural hematomas that can actually cause blood to actually spread within the brain linings, outside of the brain linings and inside of the skull, and those can actually cause increased intracranial pressure, cause coning, cause respiratory failure, and immediate death in a very short period of time. So whilst you're there with your relative at the time when you're actually there, always the question is, are you okay? Is things okay? And make sure that they're aware of what's going on. Do you know who's in front of you? Those are the very, very subtle signs that basically there's nothing going on with the brain at the time, or very little going on with the brain in terms of bleeding within the brain. So whilst you're there with your relative, it's important for you to know that carrying on a conversation with them and they're awake and alert makes you feel good, that at least there's nothing. But in the event of that person actually now going from a cognizant state in which they recognize you to a state of which they're not even able to recognize you, then you start to ask the doctor's question immediately, doctor, is my relative okay? Is there any signs of bleeding within the brain? Because now she was coherent, and being able to discuss things with me lucidly, and now she's not able to discuss lucidly. That's a sign that basically there's evidence of cerebral edema, or it could be even as a result of the drugs that you take. But you at least need to be able to address that situation with the nurse or the doctor in charge at the time it's happening. So being there is important for you to observe, to talk, to engage. At the same time when you do that, you're able to establish in your own minds that your relative is awake and alert, because the most serious injury is to the brain. You also look at the eyes themselves. Are the eyes nice and focused, or they glaze? Are they looking as if they're looking beyond you? Those are not good signs. Are the eyes fixed? Sometimes we put you on a ventilator after an injury to decrease the cerebral edema. We put you on steroids as well at times to decrease that cerebral edema. But the ventilator itself, you have to at least make sure that the person is knocked out before you actually put them on the ventilator. So at the time you ask them, is the state of consciousness of my relative a reflection of the ventilator you put them on, or is it a reflection of the injury sustained to the brain? Those are questions you need to ask and make sure you're aware of it, so you're there monitoring yourself, because no one will have more interest with your loved ones than you yourself. The other injuries that we tend to look for is evidence of bleeding from the ear, the nose, the throat, and make sure there's no fresh blood coming from it. Obviously, soft tissue into the face will result in bleeding in those particular areas. And you can actually recognize it by peeping up the nose into the mouth itself. You also look to see if there's a tracheostomy tube, which makes you aware that that tube is in the trachea, allowing your relative to breathe. What that does, the ventilator then breathes for the person at a time. If there's evidence of facial fractures, then in that case, to stabilize the face and allow breathing not to take place through the mouth, you may end up having a tracheostomy tube put there, or you might have an endotracheal tube through the mouth, at the side, pinned to the side of the mouth, and going into the respiratory tract. It doesn't mean that your relative is much worse off because of the tracheostomy tube. There may be the reason for the tracheostomy tube to assist in creating an airway, an air passage, so that the machine can breathe for them, but also it makes you aware that there's something else going on above the head. That in itself, it looks much more sinister than it should, but for us, we need to at least make sure that that tube is patent at all times and the relative is not gasping. When we look at that endotracheal tube as well, it can be planted on the side of the mouth, and it doesn't look very, very nice. It doesn't look very aesthetic, and it makes us feel afraid that something else is happening. But it also makes you aware that there's evidence of trauma to the face itself, or there's compromise involving the proximal part of the breathing mechanism. The other major thing we worry for, especially with these severe blunt trauma that occur, is the evidence of the injury to the neck. Cervical fractures, even though not common, or cervical displaced fractures, even though common, the long-term sequelae or the immediate sequelae of a transection of the cervical cord is in itself a very, very serious injury, because transection that occur of the cervical cord or the vertebral cord over the cervical region, if it involves the area above the second and the third cervical vertebrae, can result in immediate death. If it occurs below that, it can suppress the respiratory center. If it occurs below that, say C5, C6, then you're completely paralyzed. The chances of recovery after those injuries are basically slim. The issue with long-term rehab and being able to rehabilitate yourself from those injuries sometimes is much more a promise. And I have yet to see somebody who's had transection of the cervical cord or subluxation of the cervical spine without having an operation really recover to the extent. Yes, you can walk, and that's a gift. The issue about that, a lot of times you end up being a paraplegic. And basically the rest of your life spent in rehabilitation, etc. But worse than that, most of your bodily functions are affected. In the next discussion, we will continue where we left off, at least injury to the cervical spine. So we try and focus, at least today, on that cousin of mine involving an incident, an accident as it was, and for your relatives, what to look out for when you actually go to the intensive care, or you go to the multiple trauma center, or you go to the emergency room. Look for those signs in the head, neck, ear, nose, and throat, especially the signs of coherency in terms of discussion. That is all for now. In the next discussion, we'll try and look at the other parts from the neck downwards in terms of multiple traumas. Thank you. We will continue our discussion on multiple traumas to the body, especially after things like motor vehicle accident. And coming back to the case of my cousin Esther, who was involved in a motor vehicle accident, in fact, severe blunt trauma to the body after being pinned against a gas pump, just standing at a gas pump, pumping gas. It shows us that accidents can occur anywhere, so at all times we should be prepared. What is common to it is what do we do after those incidents in which we feel that the life of our relatives or the life of our very close ones are being threatened. In the last discussion, we mentioned some of the signs that we look for involving the head, the way your relative is looking at you, not with glazed eyes. They're able to focus on you. They're able to communicate coherently with you. They not have obvious evidence of bleeding from ear, nose, and throat, even though they're in the emergency room or in the intensive care unit. At least if you're aware of some of the factors, that some of the complications of head injuries at the time of an incident like this, an accident, when you're still waiting for the signs and symptoms of head injuries or other injuries to develop. We mentioned the subtle signs of bleeding within the brain, from increasing headaches to not being able to focus to total loss of consciousness. Total loss of consciousness for us is a very sinister sign. It means there's bleeding within the brain itself. We mentioned bleeding within the brain does not only occur in the brain parenchyma itself, not only the brain. It can occur within the meninges, the linings of the brain. It can occur within the lining of the brain, the outside lining of the brain, and the interior lining of the skull, which is a subdural hematoma, which can actually cause coning and actually cause the brain stem to become compressed and actually cause death in a very short period of time. We also mentioned the way when we look into the emergency room, we find the evidence of breathing mechanisms to help the lungs to expand. They're not as bad as they look, but it also alerts you that there are additional injuries that are taking place, either within the lungs itself or within the proximal portion, the pharynx, the trachea, the bronchus, the proximal portion of the bronchus, or the trachea itself. Obviously, the implant of a tracheostomy tube, after having an endotracheal tube in your mouth for a while to assist you with ventilation, means that the injuries that are occurring are probably going to take a longer time to heal. Now, when we look at the trauma that takes place, one thing we discussed the last time was injury to the neck. Because after such a severe impact injury, with a whiplash injury, with a hyperextension, hyperflexion force of it, you can actually cause the damage to the spinal cord itself, but you can also cause damage to the vertebral column. Damage to the vertebral column, whether or not be a stable fracture or an unstable fracture, can actually result in compression of the nerve root as it comes off the spinal cord. Remember the nerve root that actually supplies the arm itself, C5, 6, 7, and 8. When we look at the neck, let's say this is the portion of the neck we have here, C1, 2, 3, 4, 5, 6, 7, 8. When we look at it, this one controls the diaphragm, C2, 3, and basically if it's damaged or transection of the cord, you will not be able to have diaphragmatic breathing. You also can suppress the respiratory center and the cardiovascular center and cause immediate death. The injuries below C5, 6, 7 result in injuries to the heart, and if it actually results in transection of the cord, meaning the injury to the neck itself, if it's stable, if it involves the vertebral column, even if it's a crush injury and it's stable, it will not compromise the vertebral, the nerve root as it comes out, or the vertebral, or the spinal cord, as it comes through the neck. Remember, the issue about the neck injuries, it's not how bad the bone looks, but what is the integrity of the spinal column, that actually when the spinal cord comes through that particular spinal column, and the nerve root that comes out from the ends of those, especially in these areas when we're looking at them. This is the vertebral artery here, but this is the spinal cord. The issue about that, if the spinal cord is compressed, that will result in nerve deficit from that level all the way down. So it becomes a very serious injury. Going back to the case of my cousin, basically she had fractures involving the ribs, C7, C6, C7, C8, on the right side, on this side. So let's put this diagram against here. If she had fractures involving the rib fractures, of the 12 ribs we have, basically she had fractures involving the 6 and the 7, which is under the breast itself, and I think 8 and 9. But let's look at where this is in terms of the chest wall. So you're having fractures over, obviously impact to the breast, you're going to have soft tissue injury to the breast itself, and obviously pain. But what lies behind it is the lungs on the upper part, and below that lies the liver. In her case, she had difficulty breathing. So the issue here at that time was whether or not, with the rib fractures, if in fact there were evidence of rib fractures involving two segments here, what happens in that, you get a flail segment. And then now you're unable to breathe because that segment is now broken. And every time you take a big breath in, it goes in and out, and you're not able to have a proper respiratory excursion. In addition to that, multiple fractures to the rib results in injury to the lungs itself. But where does that injury occur? Does it occur in the lung parenchyma itself, the body of the lungs? No, a lot of times that injury takes place on the pleural cavity, where it is bleeding into the area between the pleural space. Blood into the pleural space will prevent the lungs from expanding. Also, in addition to that, you have to put a thoracostomy tube in order to drain the lungs. You can also have a complete collapse of that lungs on that side, causing the entire thoracic cavity to shift to one side. Just imagine this lung is collapsed. That empty space now created caused the heart to be shifted to the right side, and now that lungs re-expand to the other side. So now what you have now is not only the fact you can actually cause the entire thoracic cavity to be shifted to one side, severe difficulty breathing, but also at that point in time start to compromise the cardiac function as well. So injuries to the chest itself, at least you have to understand, if you have a relative with an injury to the chest and the doctor is telling you there are multiple fractures to the rib cage itself, try and understand from your own anatomy what is beneath that injury. You look at the fracture to the rib, in the upper part of the rib, let's say it starts from the level of the first, second, third, fourth, fifth, sixth, seventh rib, and we basically say that will involve the chest cavity. So we look upon it, what is behind that chest cavity. We've got the breast, obviously, soft tissue injury, a lot of pain, but it's not going to result in anything that's going to be an emergency. What happens behind that becomes the issue. Is it a fracture involving the rib cage that's now causing it can cause a tremendous amount of pain because the nerve fibers run under that. And because the rib is itself, as we see in animals themselves, the lining of the rib itself is extremely painful when fractured. But the more serious signs of it is what happens behind the rib cage in the pleural cavity. Is there evidence of air being sucked in, so much so that the pleural space is now compressing the lungs, and you're compromising that lungs and causing that lungs to collapse? Can the fracture to the rib cause bleeding within the pleural space? That is also going to compromise the breathing and cause the thoracic cavity to shift to the other side. But worst of all, what it does, it causes you to have the inability of not being able to breathe properly. It can also compromise your cardiovascular function, either by a mechanical effect of compressing the thoracic cavity, or the simple fact of basically just the effusion of blood, and actually can result in severe anemia at that time, but can cause sudden death. I'm going to try and elaborate a little bit more on the thoracic injuries that can occur after multiple traumas to the rib, and how it can also impact on the intra-abdominal findings. That is all for now. Thank you. Let us continue our discussion on multiple traumas from blunt injuries, whether it be motor vehicle accidents, falls, etc. We discuss injury to the head, and in terms of the skull, the brain itself, injuries to the head, neck, ear, nose, and throat region. We also discuss injuries to do with the cervical spine, and the long-term sequelae, short and long-term sequelae of severe injuries to the spine. Complete transection of the cord below the levels of C5 can cause total paralysis. Above the level of C4 can actually cause sudden death by compression of the cardiovascular and the respiratory center, in a case in which we describe as coning, in which the brainstem actually sinks beneath, the levels compressed beneath the skull into the cerebellum, everything cones down into the below the foramen magnum. So now the respiratory center, instead of being within the brain itself, within the head itself, now is in the neck, that's now compressed, and we have sudden death. I did in fact have a relative who died from that after plunging into a shallow creek. Injuries below the neck can actually cause transection of the cord itself, and that can cause various levels of paralysis, depending on whether that transection is complete. Transection, all it means is that the integrity of that spinal cord itself is either contused, meaning it's just bruise, which means it can repair itself over time, either surgically or non-surgically, whether by physical therapy, long-term physical therapy, or in fact if there's evidence of compression of the cord itself from decompression by a surgical procedure. Not necessarily at open laminectomy where you open the bones themselves, but probably just realign the portions of the bone that protect the spinal cord. Sometimes when we describe injuries to the neck itself, we say that there's crush injuries, but stable. You want to hear the word stable to make sure that your relative is not going to have compromise of the spinal cord. So you're not worried about how the fracture is, if it's a crush injury. Sometimes a lot of crush injuries from falls. If the integrity of the spinal column is maintained, that's good news for you. If in fact the level of sometimes even a small fracture, but it's unstable, and can actually cause compression of the nerve root that comes out through the cervical column, then in fact we worry tremendously because of the long-term sequelae, short and long-term sequelae of decreased range of movement involving upper limbs and the rest of the body as well. Because you remember when the spinal cord itself from the neck, the rest of the body goes with it. Whatever level you have an injury to the spinal cord, it affects the body below that. Let's say we have injury to the lumbar spine. It affects the area below the lumbar spine, but does not affect the area above the lumbar spine. However, injury to the neck itself will affect the rest of the spinal cord below that region, which includes your arms, your legs, everything else. Remember, because the vertebral column is made up of the cervical spine, the thoracic spine, the lumbar spine, and the sacral spine. And basically, they all supply innervation. At another time, we'll try and discuss how those nerve roots affect the different parts of the body. Suffice it to say now, cervical injuries in themselves are considered life-threatening to the point of where we actually treat them at the site of a trauma with probably the most precautions you ever can. But here again, the two things you're faced with is injury to the cervical spine and integrity of the lungs itself. If we look at this diagram, a lot of times we go into the multiple trauma center or in the intensive care with our relatives and see that they have tubes implanted. The main purpose of that tube, whether it be an endotracheal tube that either goes through the nose into the back of the pharynx, into the esophagus, allows us to breathe. The main thing is to get air into your lungs. Or you have an endotracheal tube where we make an opening beneath the thyroid cartilage and send it all the way down into the trachea. In that case, you now know that the lungs itself can be able to breathe. The purpose of creating an artificial passage is to make sure that eventually you're getting air into the lungs. The rate is being controlled by the machine. The amount of air being sent in, the amount of oxygen being sent in and expelled is also controlled. The way you measure this is measure the blood gas to make sure that whatever oxygen you're giving is adequate enough, so at least your partial pressure of your oxygen is enough that you used to have before. The issue with that is that why we need to breathe for you at that point in time is because your lungs either has collapsed in itself, either the fact of the collapse from the outside, meaning the pleural space, over the lungs itself either has air, which now compresses the lungs inward, or it has blood or other fluids within it. Now that fluid needs to be drained. What we tend to do then is to pass a thoracostomy tube through the skin into a bag that sucks the blood out and allows the lungs to re-expand, but that in itself takes time to happen as well. In that case, you prevent that swelling, that fluid that's accumulating, that is going to cause that lung to compress. When it compresses, the lung itself compresses, but it pushes the rest of the thorax to the other side, which compromises and can cause even kinking of the good lungs itself. It can also, in a severe case, cause kinking of the aorta and the larger blood vessels within it. But in addition to that, when you have fractures of the rib, you can also have fractures and perforation of the lungs itself and cause bleeding within the lung parenchyma. But worst of all, having the fractures actually cause perforation of the linings of the heart and can cause a cardiac tamponade, meaning now instead of the lining around the heart itself, now we actually have blood in that closed cavity. Now it's preventing your heart supposed to be pumping without any pressure around it. It has the lining around the heart itself that separates the outer lining of the heart and the muscle walls and the blood vessels that run thereof. If it were to be ruptured or perforated with even a puncture wound, it can cause blood to accumulate within that cardiac cavity outside the heart, now preventing the heart from contracting. Cardiac tamponade can result in sudden death. So all of these things need to look upon. If you see a low voltage EKG, when you actually do the EKG at the time that you're seeing the patient, or the EKG has changed from a normal EKG to a low voltage EKG, it's time to start worrying. If the heart rate has actually sped up tremendously, looking at the EKG, then you worry whether or not that patient is actively bleeding or there's a compromise to the cardiovascular system. That means, is the heart itself pumping enough blood? Is the lungs itself being perfused with enough oxygen? And those are the things that make us worry tremendously. In the case of my good cousin, she also had fractures involving the lower ribs itself. Those fractures are involving the 8th and the 9th rib over the right-hand side. Now, when we look at fractures involved in that, obviously she had severe blunt trauma to that area, and that was over the liver. Her blood count dropped dramatically from, I think, around 11 to something like 8, which made us understand that there was bleeding. Once it was ruled out from the lungs in terms of having a CAT scan and our oxygen levels were okay, and we knew that she was able to breathe on her own except for severe amount of pain and being aided by a ventilator at least for a short period of time, the focus had to be whether or not there was bleeding from the intra-abdominal cavity. And bleeding from the intra-abdominal cavity, you look for the obvious sign. There was a fracture involving the rib, the lower side. Let's go back to this diagram. These were where the fractures were. Obviously, what lies beneath that is your liver. And here again, I'm telling you this not to make physicians out of us, but to make us understand that when we're looking at our relatives objectively, you're faced with them face to face. And you can look at them very objectively by how they respond to you, their level of coherence, how they looked, what they're capable of doing, and put into perspective what the doctor's telling you. You have a fractured skull, but your brain is okay. You have a fracture involving the neck, but it's stable. You have a fracture involving the lungs, the rib cage itself, but the lungs are stable. So you're able to put into perspective what injuries your relative has in terms of that particular patient. Because for you, that is the most important person on earth for you who is in danger. And by being aware of what a simple approach as to where the injuries are, you can be able to ask good questions, proper questions, but also make the doctors and nurses aware when you are seeing subtle changes that are taking place in your relative. It creates within that physician or within that medical team the level of awareness that that person is not there just looking at their relatives and taking flowers and trying to be sympathetic. They're there with a perspective eye. I'm here to make sure you live regardless of everything else. I'm here to observe and to understand that this is what you were prior to the incident, the accident. Now this is what I want you to be at the end of that. So throughout the entire period, you're aware of what those injuries are, and you're able to ask the doctor, is my mother's brain function, is my sister's brain function getting better? Is the injury to the neck going to affect her? How much more do we need to do? What do we expect in the future? So the questions that you ask are the ones that make the medical team understand that you know something of injuries and you're able to assist that person, not because you did not have any formal medical training, means you cannot ask proper questions. You definitely can ask proper questions. But you make the team aware that you know what are the questions to ask, so they're also aware, did I miss this? And they ask themselves questions, and us as physicians always do that. You ask a question by a relative, you don't dismiss it because you think you're the doctor in charge. It plays in your mind for a while longer, and then you address it. And when you see that relative, you address that identical question that was asked because you're aware that people there have a level of knowledge, but your interest is not against litigation. Your interest is, let me make this patient survive to the best of my knowledge. But I'm also want the assistance of the relative to say to me, ask me the right questions, and I'll give you the proper answers. So you're aware what to expect of your relative at the time they're recovering, at the time they're discharged, and what to expect as long-term sequelae. That is all for now, and we'll continue this discussion on multiple trauma. Thank you. As we continue our discussion on multiple traumas involving the body itself, and we start to have an approach that we as patients can have when we enter into the hospital setting, not only are we overwhelmed with the fact that a relative has been involved in a serious accident or incident, but we were able to put our feelings a little bit aside as we try and evaluate what are the proper questions, what are the important questions we should be asking the medical team. We may not all be at the same level of function and in terms of expertise in medicine, but at least we should all have some idea as to what are some of the more common things that occur. And even if you're told something, you're able to ask a further question as to say, what is it that I can expect if there's an injury to, say, the head, to the neck, to the chest, to the abdomen, to the pelvis? What are some of the further questions I can ask the medical team, so at least I know what is the best scenario, what is the worst scenario? Even 2 questions to be asked. The purpose of these talks are mainly to educate the layperson as to the questions and the things that you face with, or some of the things that you see when you enter into a trauma center or see your relative in a bed in intensive care or going through rehab subsequent to an injury, subsequently to severe injuries. The purpose is not to give you a complete medical education, because that is not going to be possible. But if we are able to understand the process, we're able to ask the proper questions, and we're able to get proper answers from the relatives who know a little bit more. A lot of times I go into these trauma centers, and actually when my days of working in the emergency room, etc., I see the faces of patients or relatives being totally overwhelmed by seeing their loved ones in straps, in tubes, all over the place, in drips going left, right, and center, remembering what they were before and now seeing what they are now. I had that similar experience just a couple of days ago with a very close cousin of mine, and I understand it a little bit more now, or having revisited that situation. What is it that we as patients tend to go through when we see our loved ones and we get overwhelmed with the tubes, etc., and the lines, etc. But I know fully well that if we step back a little bit, there must be some family member who can take charge and say, let me take charge of the medical aspect. The emotional aspect, obviously, as a mother, there's nothing that can separate you from your child, or as a child from your mother. Those feelings are difficult to get beyond the look of the person to get to where the tubes are. And it's sometimes even difficult for a physician who's gone through this on numerous occasions in their life, or probably go through it on an everyday basis, to even fathom, to think when they see their child there, or their mother there, or the rest of their family there, they're not able to separate. And it's difficult at times to separate it. But what I'm asking here is that even when you're there and you find that they're recovering and you separate the emotional aspect, try and focus on where things are and where the injuries are. For instance, injuries to the head, to the neck, to the thorax. You're able to put them in perspective in terms of, is it going to affect brain function? Is it going to affect breathing if it happens in the neck? Is it going to affect the function of the limbs because of the spinal cord? In the thoracic function, is it going to have long-term sequelae in terms of lung function or cardiac function? The last 4 discussions, we elaborated tremendously on those particular regions. Let me go back to the same relative of mine, Esther, basically with the fracture that she had involving the rib. Her hemoglobin dropped tremendously, so we wanted to know whether there was any laceration to the liver itself, or whether there was bleeding or hematoma involving the liver capsule itself. Fortunate for her, she entered the injury in a state of chronic anemia from another process, and basically she did have a small contusion to the liver itself. That contusion itself did not need an operation. However, if her blood counts continue to drop, they may need to have done suturing of the laceration or taping the laceration over the liver. What that would have entailed is entering the intra-abdominal cavity, not maybe with a laparotomy right through, especially if it continues to bleed. You will have an exploratory laparotomy, which means you have to open the abdomen to see where that oozing is coming from. In her case, it's a superficial laceration. It is not going to result in anything, and it's going to heal by itself. It's going to form a clot, and the bleeding will stop by itself. But you keep monitoring the hemoglobin to make sure there's not persistent bleeding. Behind the liver, obviously, is the gallbladder. Perforation to the gallbladder or to the biliary tract itself is a surgical emergency. And what I'm referring to is that a severe blunt trauma to the liver itself can cause contusion to the liver, but also the gallbladder is beneath there. You also have the inferior vena cava that runs through it, and basically from severe trauma to it, you can have a laceration involving a rare injury, but when it occurs, the hemoglobin drops tremendously. There it tells the surgeon, let me open the abdomen up and see where that bleeding is coming from, or else the patient's life will be jeopardized. If we get beyond the abdomen, usually in terms of injury to the gut itself from severe blunt trauma, it usually doesn't result in vascular injuries. You can have soft tissue injury to the gut itself. More or less, you rest the gut, it recovers in time. Very little chance of having transection of any portion of the gut. But here again, the function of the gut itself, obviously in a patient, is going to take time to manifest itself, unless it is a vascular injury, and then in that case, the hemoglobin drops tremendously because there's a tremendous amount of space in the intra-abdominal cavity for oozing to take place, so much so that the blood count keeps dropping. So in the case of our relatives, we always ask the same question: is the belly soft? Is it becoming distended? Is it becoming, the hemoglobin is dropping and the belly is becoming distended? Is there something else going on in the abdomen? Today's day and age with MRIs and the MRIs available, obviously it's very much easy to diagnose when there's bleeding that's occurring, and these tests are definitely needed at that point in time when you're faced with a life and death situation. Coming back to the abdomen, the injury to the abdomen, obviously you have the pancreas that lies at the back here. Injury to the pancreas, even though rare, but when it does occur, is definitely life-threatening because of the nature of the pancreatic juices being produced, which can cause autodigestion of even the areas around it. We have damage that can occur to the kidney itself. Soft tissue injury to the kidney itself does not result in compromise to the ureters themselves. So you do have blood in the urine. It makes you aware that you're wondering whether or not there's any further damage to other organs. Could it be, is the blood in the urine coming from the kidney itself, from damage to the kidney, or is it from lowdown? Is it from the blood itself? In injuries of the abdomen, usually they take time before they manifest themselves. But always you are aware that basically there'll be some changes that take place. But if your relative is unconscious, they're not able to localize pain. They're not eating, so you're not aware what their gut function is. And sometimes the most subtle sign we have that there's something going on with the abdomen is basically in terms of the fact that the hemoglobin keeps dropping when we're not even quite sure where the blood is being lost. And in that case, then you need to have further evaluation done of the abdomen in terms of additional studies. But more importantly is for the physicians to be palpating the abdomen to make sure that there's no evidence of distension of the abdomen or swelling of the abdomen. And you look for evidence of bruising. Obviously, if you see a big black and blue mark over the abdomen itself, that makes you realize that basically there is injury to the organs beneath it. And you always are aware of this, to make sure you ask the physician, is my mom's belly okay? If she's okay, they'll tell you that it's okay. A KUB, an simple x-ray, will show normal air-gas fluid interfaces, and that will tell you, yes, at least the gut function is okay, and basically the rest of the other body functions will follow as well. But you have to isolate. It's not only just looking at your relative or what they were before and after, and what you're looking at them now, but every organ system itself has to be evaluated in its entirety. And it's not only evaluating as a global picture. You take each one aside and figure out which is it got to be affected, which is it, and what is the effect of it having on the other body systems. So you take the brain itself, you take the cervical spine, you take the neck, you take the lungs itself, you take the abdomen. And within the abdomen, you take the liver, you take the spleen, you take the pancreas, you take the gallbladder, you take the rest of the gut, you take the inferior vena cava, the aorta, you take the kidneys behind it, the suprarenal glands. So everything that's being assessed by your physician has to be done in the most careful fashion in terms of you're not able to go inside like a car and actually take out parts and remove it. You have to use what is there that's available from either secretions coming out or from parameters being monitored to make that decision. But here again, the more you know, the more important questions you're able to ask that medical team that's going to give you the better answers. And also the ultimate outcome is more interest you have in your own relatives at the time of an incident makes the medical team feel as, yes, they need to put more effort on their end of it. That is all for now. In our final discussion on multiple trauma involving accidents or severe trauma to the body, we mentioned injuries to the other body parts. In the patient we were discussing before, She also sustained multiple fractures involving the pelvis. Multiple fractures involving the pelvic. If you look at the pelvic bone itself, obviously you have the sacrum, or the lower part of the backbone. You have the ischium, the lower part here. You have the iliac bone. Then you have the hip itself. In the case of our patient, she had a fracture involving the superior pubic rami, which is this bone, and the inferior pubic rami, which is this bone. But just imagine what is behind this. The bladder is just behind this. In this particular diagram, if you were to look at this, this is where it lies, just above here, and the bladder is behind him. She was lucky not to have had any laceration to the bladder itself, but that would have easily been ascertained, especially from checking the urine to see if there's any blood in the urine. But more importantly is the membranous urethra that you worry from, because that's difficult to heal, and that's difficult to diagnose and to treat as well. And when you're monitoring urinary output, you also have to make sure that a catheter is into the bladder and not in the urethra being stuck. Damage to the pelvic bone in two regions make that an unstable fracture. So obviously, if the pubic symphysis, or the bone that joins the two portions of the pubic bone together, if they're intact, it makes this fracture less dangerous. Fortunate for this patient, she basically had just fractures involving undisplaced fractures, which makes it stable. So after a week, she'll start to rehab in terms of moving around. Extreme pain, but at least at the same time starting to ambulate. She also had a fracture involving the head of the acetabulum, which is the inside of the hip bone itself, the trochanter, or the bone that actually the head of the femur, that was not fractured, just the acetabulum. Here again, the fracture itself was stable, it was not compressed, it didn't have to be decompressed. So we expect full function involving the hip joint itself. But always at the time when you're evaluating the injuries, the reason I'm telling you this is that you hear about fractures to the pelvic bone. You have to ask the right questions to your doctor. Is it a stable fracture? Is it an unstable fracture? Is it going to result in long-term sequelae of damage to the bladder? Did it damage the tube that goes from the urinary bladder through to the urethra? But it also makes you alert yourself. Is there any other injury within the pelvic region? Within the pelvic region in the female, which has the uterus and the rest of the reproductive organs, plus the lower end of the rectum inside there, and the sigmoid colon. In the male, obviously the prostate and the bladder itself. So a blunt trauma to cause fracture involving the pubic bone makes us wonder, is there any other injuries that can occur? And the most important organ for damage here is your bladder. And the diagnosis of this is always, the first symptom is to make sure there's no blood in the urine. And no blood in the urine and a good urine output says to you, yes, at least you're fortunate this time around. Issue about that, it also tells you whether or not the intra-abdominal injury you had does not involve the kidney, because the first sign of any sort of damage involving the kidney, the urethra, the bladder, is going to be blood in the urine. So asking the relative to pass urine frequently, or looking at the bag, the catheter bag, that urinary bag that's at the bedside, as to say they document the urinary output, they document the color, they test the urine for evidence of blood in it, all are very, very important things at the time of an acute trauma. Even subsequent recovery, it's also extremely important that we focus on these things as well. In the period of time, we're expecting our relative to be on bed rest, especially they spent a week, 2 weeks in the hospital on bed rest, either with all the feeding tubes, etc., the IV lines, the central venous pressure lines, the endotracheal tube or the tracheostomy tube. You also worry about one big thing, which is a patient on prolonged bed rest with definite evidence of injury to the pelvis. The chances of deep vein thrombosis as a result of a clot formation within the deep veins of the calf is one of the worst complications of bed rest. And there's certain things here that makes this thing so much more common in a patient with an injury. Because with a pelvic fracture, you secrete all sorts of hormones and other chemicals that increases the stickiness of the platelets, increases the formation of clots and the propagation of clots within the veins itself. So at all times when you actually by your relative's bedside and you give him permission to expose the legs to make sure that there's no swelling of the legs, there's no tenderness. The physicians themselves, I'm very much, and the nursing staff, very much aware of this complication, because the complication of a deep vein thrombosis, as it propagates a clot from the leg, the calf itself, up to the leg itself, that clot in itself can propagate to the lungs, and it causes a pulmonary embolus. So one of the worst complications of the bed rest is the formation of the clot within the venous system in the leg that propagates itself all the way up into the inferior vena cava and goes to the lungs itself. That in itself can either cause showering pulmonary embolus, which results in mild shortness of breath and sometimes mild hemoptysis, meaning spitting up a little bit of blood. But more importantly, we're not able to be spitting up because we have this endotracheal tube. But we've got to be aware at all times that this is one of the major complications and cause of sudden death, especially massive pulmonary emboli. Shallow pulmonary emboli can cause shortness of breath and mild hemoptysis. In addition to that, if you've had fractures to the ribs, remember the most important thing at this stage is to make sure that the lung functions return to normal. What we're looking at that stage is to make sure that it's vigorous pulmonary exercise, whether in terms of breathing, that same breathing mechanism, incentive spirometry at the side of the bed. Every 10 minutes, you breathe in as massively as you possibly can to re-expand the lungs. If you do not re-expand the lungs, you will cause collapse of the bases of the lungs on this part. You can also form, the secretions can also form and help to form basal atelectasis, which means that part is collapsed and will never return. Your role is to make sure you re-expand the lungs as much as you can. Increased amount of secretions can increase the risk of bronchitis, even a lobar pneumonia. And those are the things you try to avoid, because now you have multiple trauma to the body. Now you have, in addition to that, an infective process. That infective process now complicates your general medical condition, and now you have multiple organ damage. No, not in a non-infective state anymore, now in an infected state. That also now complicates the entire picture. So you try to avoid infections at all costs, especially with multiple trauma, because it can result in much more worse complications or excessive burden on yourself when in fact you should have just been able to recover from the blunt trauma into the state of rehab, and then finding out what your prognosis is going to be, or what you aim to have as your prognosis in goals. What is my prognosis in the next 2 weeks? Am I just in bed all the time? I'm going to be in rehab the next 2 to 3 weeks. I'm going to be expected to be off work for the next 3 months. I'm not going to be expected to be able to pay my bills. How do I expect for those to be paid? How my family is going to function in my absence? How is it I plan to cope? So if you set yourself goals, or you assist your relatives in setting themselves goals, and say, when do you think I'll be able to be functional? God willing that we are alive and well at that time. Be able to function. What is our level of functioning is going to be within the next 3 to 4 months, and be realistic about it and be able to plan accordingly. So part of the goal in terms of the education as to the injuries is also to figure out what am I expected to be some of the complications of these injuries. What am I expected to do in terms of functions at home, in terms of the work I'm expected to do, in terms of my functions of a husband and a wife, in terms of function of taking my kids to school. What are the things I'm able to do that I was able to do before, now that I cannot do? Am I going to be able to tolerate noises in the house, especially with evidence of injury to the brain? Then the noise level has to drop. Do I need to be taken to the doctor every 3 to 4 days for my evaluation, or physical therapy every day? Who's going to be taking me? And those adjustments have to be made within the house. So when you evaluate your injuries, it's not only the doctors and the nursing staff will evaluate your injuries, but you also put a time frame and a perspective within your family unit as to who is going to be responsible. And at the time when the incidents are happening and the developments are taking place, it's probably the best time to discuss this. So at least somebody who says they have an interest in you at the time you're injured will have an interest in you after your recovery phase, and you tell them, can you assist me now? And then when I'm recovering, to take me. Oh yes, I will. And promise them that they were going to make sure that they're there for you at the beginning and the end. So that's how you can ask for assistance from relatives. That is all for now. I hope this has been of assistance in terms of some of the injuries that some of the ways and means we can help ascertain the degree of injury, ask the pertinent questions to our medical staff, and also at the same time plan the recovery process for our relatives, and do not make it a burden, make it a structured approach in which we're able to address the injuries, the recovery, and basically how is it that the family unit can work together in terms of helping that one particular person who needs the help most at that time. That is all for now. Low back pain is an extremely common presenting complaint to a family practitioner and internal medicine. In fact, on an average day, I would say that close to approximately 25% of our patients would have some symptoms, some complaint that is related to a low back pain. Low back pain as a physical complaint or from a patient, in terms of ruling out what are the common conditions that cause low back pain apart from the spinal column. If you were to just forget about the spinal column and basically start forgetting about the nerve roots or the muscles itself, what are some of the things that can cause low back pain outside of the spinal cord, the nerve roots that come out of the spinal cord, and the musculoskeletal system of the lower back? Some of the things that a patient, and a female patient obviously, is to rule out any organomegaly involving the pelvis, whether it be from the uterus, enlargement of the uterus, fibroids within the uterus, any evidence of any bladder pathology, or anything to do with the kidney being a retroperitoneal organ. In terms of the male, obviously again the kidneys being a retroperitoneal organ, and basically we can try and rule out any of these conditions that can result in upper to lower back pain involving the kidneys, the ureter, the uterus itself, and the bladder itself. Any ovarian structure, whether it be related to the ovary itself or the ovary and the fallopian tube. In the male itself, related to low back pain, whether or not it's coming from the kidney. The renal stones can present with low back pain as well, but they have other symptoms associated with it. In addition to that, any disease associated with the bladder and the prostate itself. Having said that, let's think about what are some of the more common complaints that we have with low back pain, and look at the spinal cord itself and the implications of any destruction involving the spinal cord. If we look at the lower back itself and look at the anatomy of the back, obviously we know the cervical, the vertebral column is made up of the cervical spine, the thoracic spine, the lumbar, and the sacral spine. The lumbar vertebrae is made up of the 5 vertebrae, L1, 2, 3, 4, and 5. And this is extremely important to know the anatomy, because in my private practice as well, in terms of the persons with no fault motor vehicle accidents, at least 70% of them will have some degree of low back pain as a presenting complaint. In the workers' compensation patients that we see as well, there's also a high number of them, probably over 50%, who would have injury to the back. And it is important, once we understand the anatomy of the lumbar spine and the nerve root and the cartilage in between, it is very easy for us to understand why is it sometimes that a low back pain is so difficult to treat, where the sequelae of pain that radiates down to the back of the leg. Why is it sometimes the knee jerk reflex tends to be affected, the ankle jerk reflex tend to be affected, and not all low back pain are the same. You may have a lower back pain, but if it involves, let's say, the L4, L1, L2 region of the lumbar spine, you will not get any pain. That even if you show evidence of a disc prolapse here, and let's look at the anatomy again. This is the vertebral body. This is one of your vertebrae, made up of the vertebral body, the makeup of the spine of the vertebrae. The spinal cord sits inside the length of the spinal cord throughout the entire spine, and the nerve root comes out through these facets. Looking at it from the side, you will see evidence of the nerve root coming through the neuronal foramen, and this is where it comes through. When we look at the integrity of it, this is when it's totally intact, with the nucleus of the intervertebral disc itself being intact, with no evidence of protrusion. There's no compression of this nerve itself, and this is the undamaged spine. Looking at it from the side, the two bones themselves are cushioned by this vertebral disc, which is a sort of a cartilaginous disc, which is like a sponge, a thick sponge that buffers the impact of low back pain. But when this same buffer itself undergoes damage and becomes compressed, then the nucleus, the soft part of it, protrudes into this area and can cause damage to the nerve root. So when you look upon this, this is a disc bulging, and this is a transverse section. You're taking a section through the body like this. The nerve root itself was the disc itself was damaged by the simple fact of the impact injury, whether it be a motor vehicle accident, where it's an accelerating, decelerating injury in which the spinal cord, the lower vertebrae, the lumbar vertebrae become deranged, and basically the disc space itself becomes disorganized, and we have evidence of this. Or when an impact injury of bending to pick up something heavy, you actually cause compression of the intervertebral disc. What happens in this case, look at what happened. Just a minimal amount of trauma actually causing the disc itself, which was normally a nice hemispherical structure with the soft part of it and the cartilaginous part outside, and it sits with that cushion. Now that cushion is ruptured, and the soft portion of it now is compressing the nerve root. When that compression occurs in different areas, it produces different sorts of symptoms. So it is important for us to understand the anatomy. You have low back pain. You have 5 lumbar vertebrae, and you have your 5 lumbar vertebrae, and then you have your sacrum, which is made up of the 5 sacral vertebrae, and these themselves are really fused before. But this part of it allows us the luxury of being able to bend. This is what we sit on, and the coccyx is really our tailbone. This portion of it doesn't affect us, except that state called spinal stenosis and basically cauda equina syndrome. But that in itself I'll talk about later. But just to understand, the majority of our patients who present with low back pain, if you understand the anatomy of the lumbar spine, if you understand the bony structure that is cushioned by this disc in between, and the nerve root that runs through it, it's not the spinal cord. The spinal cord is intact within. This is where the spinal cord is, and that lies inside of there. But then the nerve root runs out from both sides of it. And depending on the level at which the nerve root is being compressed, that will determine the degree in which you have experienced pain, either pain down through the buttocks, down to the knee, below the knee, or down to the ankle. Low back pain is such a common thing, we must as patients understand the lumbar spine as best as we can. Continued our discussion on this very common topic of low back pain, and haven't described what the lumbar vertebrae looks like, since that's where most of the pathology between the lumbar vertebrae and the upper portion of the sacral vertebrae exists. But let's not forget that in addition to a normal lumbar vertebrae and a normal sacral vertebrae, you can have other causes of low back pain. The last topic I alluded to, evidence of degenerative disc disease, and I'll continue that discussion, basically how the disc becomes damaged. But just in this diagram to show you how, in fact, a normal disc with a normal disc separating the 2 vertebrae, and this is L3, L4, L4, L5, and the first sacral vertebrae. But notice this, between L5 and S1, there's evidence of a disc prolapse. So when you take an X-ray, you will see these changes. You will see the change where the actual structure, the actual size of the vertebrae has been compressed. There's evidence of spondylolisthesis, which is the bone itself, and this is a chronic injury. The bone itself is against the bone, and it actually causes osteophytic lipping, which is like a bony projection that occurs here. But notice also that the disc space is narrowed. Now just imagine that same nerve root that I showed you that comes out through the foramen here, and the spinal cord runs behind that, and it comes through. That nerve root now can become compressed. And that is what gives you the paresthesia or the numbness that goes on behind the leg or the front of the leg or wherever it is that actually perpetuates the innervation of the vertebrae of the spinal cord as the nerve root comes off between L2, 3, 4, and 5, and S1 and S2. And basically this is the structure of the sacral vertebrae itself. But that is one of the causes, this disease. But you can also have facet syndrome, where you actually have a part of it, apart from an injury, that the bone itself from the vertebral column is actually compressing it. This, however, is much more common for us to find as a result of an injury, whether a motor vehicle accident, a work-related injury, or just trivial, just heavy lifting in any of the stuff we do at home as well. This is much more of an advanced disease where the bone itself actually is causing compression of the nerve. We also have spondylolisthesis, which is actually part of a bony defect that's basically causing compression of the vertebrae, and actually is causing the bones of the vertebrae are not aligned as perfectly as in a normal vertebrae, and they tend to slip over each other. This is L4, L5, and it's slipping over this way, resulting in basically the spinal cord being compressed. Transitional vertebrae itself can also cause that syndrome. Very uncommon, but basically it can also occur in about 6% of persons and can also result in low back pain itself. The enlarged portion of the transverse process of L5 is fusing into the sacrum, now causing narrowing of the nerve root, and that can also cause pain. These can be incidental finding on an MRI that's done or an X-ray that's done to show us the cause of low back pain. But simply having them there does not explain the cause of low back pain. It may just be there as a coincidental finding. When we also can be faced with subluxation involving the vertebrae, where subluxation just means they slide on each other. Mainly they're not aligned properly. And subluxation, one vertebrae being out of alignment on the other. And when we notice that the vertebrae itself is tilted to one side, that in itself will cause compression of the spinal cord as it runs through. Spinal stenosis is a condition in which the spinal cord is running through a narrow spinal column. And basically what it produces in the patient, usually with low back pain as a result of lumbosacral disc disease or the lumbar spine disease itself, usually the pain that is actually relieved by rest. Basically after long, prolonged rest and therapy. In spinal stenosis, the patient usually finds that when they exert themselves, when they walk, they tend to get relief of the pain within the legs, the pain and the numbness in the legs itself, and that's because the movement tends to make the spinal column itself, the spinal canal itself, where the spinal cord runs through, either by flexion or some other positions, they tend to relieve the pressure, and hence the numbness experienced by the spinal column, the spinal stenosis, when the spinal cord itself is compressed, by movement allows the laxity of that, and the patient experiences symptoms that are much relieved by exercise or even flexion. In the case of lumbar disc disease, it tends to be worsened by physical activity. Hence, in the cases of lumbar disc disease, which is much more common, we usually advise patients to actually rest, to actually allow the swelling to decrease. In spinal stenosis, the patient will tell you, my numbness down the back of the leg is relieved by me flexing my back and actually walking. So this is in itself not as common as degenerative disc disease, but still exists. And you have to give the patient at all times the benefit of the doubt and not assume that they're crazy, that this disease is relieved by exercise. In the case of tropism, the joints themselves are narrow, very, very uncommon in terms of causing low back pain. So low back pain in itself, as we try to explain with this particular diagram, showing how the vertebrae themselves doesn't have to be deranged. There can be other things involving it, whether it be facet syndrome, spondylolisthesis, evidence of subluxation or transitional vertebrae, whether or not there's any bone, extra bone that's causing compression, whether or not the bones themselves are sliding on each other, or whether or not you have evidence of a congenital abnormality in which the bones themselves are not aligned properly. They in themselves can cause evidence of low back pain, but they're usually the exception rather than the rule. The most common cause is when the integrity of this part of it, the bone of the vertebral column, the disc itself, the nerve root themselves are deranged. Those are probably the more common cause of low back pain that we tend to see in our family practice. As we continue our discussion on low back pain, having gone through what the vertebrae looks like, let us at least try and understand why is it that some of us will have low back pain by itself without any concomitant nerve compression, whilst there are others who may get evidence of paresthesia or numbness or pain that radiates from the lower back through the buttocks area. Some of us will have pain that comes to the anterior or the front portion of the leg and probably stops at the knee or even go below the knee. Some of us will get pain that just radiates to the buttocks area. And when I say radiates, it's like a vague pain that you get in the lower back and then it appears more prominent in the buttocks area. And you know you did not fall on your buttocks, but yet you have pain that radiates down to that area. You may even have pain that radiates down below the knee. Some people may even complain to you that they have pain that radiates down to the sole of the feet. When we look at the anatomy again of the spinal column, we've gone through again what it looks like with the vertebrae and the intervertebral disc, which is made up of the nucleus pulposus and the nucleus annulus. The annulus is what keeps the contents of the disc intact, but when it ruptures, that results in that nucleus pulposus just rupture in, and the contents of it can cause compression of the nerve root. Is it such a simple thing? Yes, it's a simple thing. If you understand the level at which a nerve root comes off, and at least where is it that you get the radiation of those symptoms. When you look at the spinal cord, when the spinal cord itself ends, it basically measures the branches of these then form the sciatic nerve, which passes through the foramen. Now, when we look at this diagram, we can see evidence when the L3, these are the double vertebrae, this is L5, L4, L3. If there's compression of the nerve root between L3 and L4, this nerve root is the one that's being compressed. But this nerve root is the one that innervates the anterior portion of the leg. The front portion of the leg is the one that's being innervated by this. So when that nerve root is being compressed, it can cause pain or it causes numbness or paresthesia that radiates down the front of the leg. It will also cause, because the L3-4 distribution of the nerve root, the sensory supply of the nerve root is over this area of the leg, and also the posterior portion of the buttocks area as well can, when the L3-4 is being compressed, and it will end at the anterior portion of the knee itself. Here again, it always have to be a classic distribution of the pain, because if the nerve root is affected completely, if the disc completely affects it, you will get the entire nerve root distribution being affected. If the entire nerve root is not being affected, you will get approximately something like this, where the pain radiates down the front of the leg, ending at the knee, and maybe distribution at the back of the leg itself. Lower down between the nerve root L4 and L5, when we look at this, between L4, L5, that nerve root compression is on the, when you look at the buttocks area, it goes all the way down to the mid-calf and ends there. If we get a patient complaining of it going all the way down to the bottom of the sole of the feet, then we know L5, S1 is also affected. You can get all three affected that cause pain that radiates down the front of the leg and towards the entire posterior aspect of the leg. Yesterday I saw a patient who presented with buttocks pain radiating all the way down to the sole of the feet, with loss of flexion, with the reflexes involved in the ankle and the knee because her nerves was being compressed. She had evidence of a complete case of sciatica. Going back to here again, let's look at this nerve root as it comes out. This is the portion of it, the disc in between. That disc is now compressing the nerve root that lies between L4 and L5, hence causing the distribution of the numbness on the posterior aspect of the buttocks area and the back of the leg, ending at the mid-calf, and just a small area between the big toe and the second toe. When it involves L5 and S1, and it is so important for us to remember these things, because it's when we correlate the patient's symptoms with the MRI findings that you can actually say exclusively that this is a result, this patient never had these symptoms before, and this is now as a result of the injury to the lower back, whether it be in a motor vehicle accident, whether it be in a workers' compensation accident, or even for the own patient's edification, if this incident occurred out of the workplace or not in a motor vehicle accident. To basically say this is what is happening, and be able to guide them as to say, we have now established, either by the MRI findings as well, that definitely the distribution of your nerve compression is pointing towards the evidence of a nerve disease based on a simple fact that the disc is compressing the nerve. Now, how does it help us? If in the case we start a treatment of that patient, whether it be in forms of analgesic for the pain, muscle relaxant to help the muscles relax over that particular area, and as well in terms of either patches and heat and physical therapy, and obviously sometimes with chiropractic adjustment after the pain is started to settle, is to basically establish whether or not this patient is now having advancing disease by further compression of the nerve. And how does this present itself? With the patient having one intractable pain, there's no response to therapy or analgesics, and in the latter scenario, when we continue treating, you can have loss of muscle bulk in that patient. You can also, when you test the reflexes of that patient, find that the reflexes are diminished, much more of a subjective finding than anything else. But at the same time, if you understand where the pain, where you're having the back pain, what's the distribution of the compression of the nerve, it will probably help you to advise your doctor. Yes, I think I'm improving, because right now I used to have pain that radiates all the way down to the leg. Now it's only up to the back of the knee area itself, which is saying to us maybe the area between the nerve that's coming through the spinal cord, maybe it's not as advanced, maybe it's now the therapy is working or the medication is working. So it's extremely important that you realize how important it is to understand the anatomy of the lumbar spine and how the nerve comes through the spinal cord itself and produces symptoms. Having described what happens in the lower back in terms of the vertebral column, the disc space in between, and the nerve root, the similar thing applies to the neck itself. The neck is made up of the cervical spine themselves, which in an intact neck looks more or less, let's say for argument's sake, forgetting about the ligament damage, just show the cervical vertebrae, the atlas, the axis, and the remaining six cervical vertebrae, and the spinal cord running in between. Here again we have the nerve root as it supplies between C1, C2, C3, C4, forming a brachial plexus between C5, C6, C7, and T1. And that forms the brachial plexus, which then supplies innervation of the hand itself. That same innervation of the hand, you can actually figure out from between the areas that are being compressed. If it involves C5 and C6 with the nerve root, it will cause weakness of the biceps muscle. C7, T8 will cause weakness of the triceps muscle, etc. C5, C6 will cause weakness of the brachioradialis. So that patient will experience either decreased strength or sometimes numbness itself if both the motor and the sensory part is affected. But here again, only to understand is that different portions of the neck that's affected, as well as the lumbar and the lumbosacral vertebrae, will result in particular numbness and decreased strength over particular areas. If in fact the brachial plexus of the neck is affected, the nerve root from the neck is affected, it will result in that. But it's important to realize that it's not by accident that explanation is given. It's based on the complex anatomy that takes place in the neck itself. If we also understand a little bit of the anatomy itself of the neck is held together by the vertebral column, the cervical vertebrae is held together by ligaments, the anterior ligament, posterior ligament, and then the interspinous ligament. Anything to do with an accelerated decelerating injury, whether it be from a motor vehicle accident, can cause subluxation of the vertebrae one on top of the other. Can also cause steering the ligament. A lot of those can result in pain, whether or not be through the ligament being ruptured, the fact of there being facet syndrome with a fracture involving one of the vertebrae. Without compression of the nerve root, you can have excruciating pain without compression. Yet you can have a patient who has got minimal trauma with evidence or basically evidence of nerve compression because of either one, spondylolisthesis, or the fact that the vertebrae is slipping on each other. Remember, these are held together because the traction force in the neck is so strong, it has to be held together by the ligaments, the anterior longitudinal ligament, the posterior longitudinal ligament. And we can see in terms of that where basically in any injury to the neck, not only do we have to focus on the fact of the vertebrae itself, but you also have to look at the ligamentum nuchae. The ligamentum nuchae is that area which is in a vascular area that is actually made up of fascia. The tensor fascia lata is the equivalent area in the lower back itself. When we look at animal models, we can also see that you see the muscular areas, which the meaty areas, and the tendon-like areas. The same thing in the human species. The ligamentum nuchae, which inserts from the base of the posterior aspect of the skull, but actually gives the support to that portion of the neck. This is avascular. And a lot of times in injury, after prolonged therapy, that's when you get a response to it, especially if it's stored. The same applies to the tensor fascia latae. It does not have a significant blood supply. And a lot of times for us, the muscles themselves, if the injury is due not to the spinal column or the spinal column, and the muscles, whether it be the buttocks muscle involved in the injury or the lower back muscles themselves, when we have to treat this area, especially tear within here, which can give excruciating pain because of the lack of the blood supply to it, it's difficult for us to treat it, and it's difficult for the patient to respond in an adequate fashion. The muscles themselves, because of the liberal blood supply to them, tend to respond much more easily. But the fascia itself, with such a poor blood supply, has to undergo prolonged therapy before. Not only are these areas not amenable to physical therapy as rapidly as the muscles are, it's basically they can persist for much longer after the incident. So what we face with is that basically when we have evidence of diseases involving the lower back, the lower back and the neck itself, we always have to take into consideration whether or not the fascia behind it is affected, as in the case of the neck here, or in fact in the case of the lumbar fascia, whether or not that entire fascia has been affected as well. So in the cases of injury to the lower and the upper back, to the cervical spine and the lumbar spine, it is not only important to differentiate whether or not the local area, meaning the superficial area of the back as we palpate for symptoms, as you and your family says, well, this is where the pain is coming from. It's coming from the back of the neck. It's coming from the base of the skull all the way down to the back of the neck. It's involving the trapezius, the muscles involving the breast bones at the back of it in the interscapular area. It is radiating all the way down to the lower spine by lower back. It's going all the way to the buttocks area. And basically you have to understand the anatomy of it first, from the outside going in. And obviously you're faced with the skin, the subcutaneous tissue, you're faced with the fascia, then you're faced with the muscles on both sides, then you're faced with the vertebral column with all the interspinous ligaments that's helping in anterior posterior longitudinal ligaments that are keeping it in place. Then you have the bony column that's separated by the discs, the separate bones that form the lower back, the 34 vertebrae that make the lower back, separated by this ligamentous disc that can actually undergo protrusion and causing compression of the nerve. So low back pain is not only a musculoskeletal phenomena, it's also a neurologic phenomena. And basically the most difficult part to treat is the fact that when you get initial relief of the symptoms, the patient feels that now I'm back to normal, and then go back and do the same physical activity that actually precipitated the first incident. And that's why sometimes it's so difficult to treat, because obviously we need our lumbar spine and our cervical spine to stand erect, and basically just walking around can cause exacerbation of those symptoms. My advice to you is, depending on the severity of your illness and the nature of the severity of your pain, is the amount of precautions you should take with low back and upper back pain. A few days ago, I witnessed a not too uncommon scenario taking place in an intensive care unit. I was visiting a relative of mine when I noticed a discussion that was taking place, very similar to discussions that I've had in the past or was privileged to have with patients regarding stroke victims. A lot of us understand that strokes, or would have understood that a lot of us have relatives who have strokes, either recovering from strokes or died as a result of a stroke. We all know what are the common risk factors that cause a stroke, basically to do with the increased high blood pressure that occurs, that cause from the whatever the condition, and most of the incidents of of increased blood pressure, we don't have an idea what causes it, but basically we know the factors that can help to control it by taking our medication, decreasing our salt levels, increase the amount of exercise, and getting back to a normal weight for our height. In the case of a stroke, it's whether or not it's an ischemic stroke or a hemorrhagic stroke, whether or not there's a ruptured blood vessel into the brain that basically causes a huge amount of blood and shuts down the brain totally, or cause the brain to cone into the brainstem, compressing the breathing center and the cardiac center in the brainstem. Or it can be an ischemic stroke in which an embolus either blocks the passage of blood into the brain itself and causes the brain to die. In this incident, there was a patient who was 74 years of age who presented with difficulty breathing. And when he presented to the emergency room, the historical perspective was that of a 74-year-old hypertensive patient who was having increasing difficulty breathing and was losing consciousness. At that time, the patient was put on a ventilator, was intubated and put on a ventilator whilst trying to find out what the diagnosis was. In a case presenting here is that when you're faced with a patient who's having difficulty breathing, the diagnosis is secondary to what you have to do to preserve the life of that patient. In the case of this 74-year-old gentleman, he was intubated and put on a ventilator. After about 12 hours afterwards, when IV lines, everything else, bloods were drawn, a CAT scan of the brain was done immediately. The diagnosis was made that the reason for his difficulty breathing was the fact that he had a hemorrhagic stroke. The CAT scan of the head revealed that there was evidence of a large amount of blood over the entire lining of the brain itself. That prognosis for that gentleman at that age, presenting with that amount of bleeding, was that it's basically going to result in increased intracranial pressure and death eventually. He, however, was kept alive on the ventilator. The issue with that in terms of life expectancy, when already established that this is a large stroke and probably the chances of recovery might be very, very slim, the decision was made to continue on the ventilator and see what happens. At that time, there was no other patient to be put on a ventilator. There are very strict rules and guidelines to put a patient on a ventilator and what the eventual outcome. However, in a case has to be established that there is no brain activity. It was established within 24 hours that the gentleman had EEG of the brain, showed there was no brain activity. It also showed there was no blood being perfusing the brain itself. That's a legal definition of brain dead, as established. But yet there was difficulty having the relatives to agree that this 74-year-old gentleman should be taken off the ventilator. The argument was very simple. Why did you put him on the ventilator for the first place? Why are you taking him off the ventilator? Do you think he has any chances of life expectancy after? The decision to put him on the ventilator was made because, and I've seen this played out a number of times in my own patients, when presented with a relative who's had a stroke, especially not a 74, a younger patient who's had a stroke, who you know is going to be in a persistent vegetative state, have been removed from life support. The decision to be made by the relatives in terms of removal from life support, and all of us will be faced with very tough decisions in life to make. And this is one of the toughest decisions to make, is when do you decide to take that person off the ventilator? When it is established that that person is brain dead, meaning no electrical activity in the brain, no perfusion to the brain, two physicians independently, one has to be a neurologist, or preferably a neurologist, makes the decision that the outcome, life expectancy for this patient with the advent of the ventilator being removed is nil. In the case of this gentleman in question, he had no EEG, there was no blood flow to the brain. The decision was easy. It was made easy because he was 74-year-old, but it was made more difficult because the relative did not understand what it means to be brain dead, and no one took the time to explain to her that basically this relative of hers will be in a persistent vegetative state, meaning probably be lying there until that time comes that he or she passes away. We can do a lot of things in addition to that, like putting a feeding tube and probably prolong life. To whose benefit? To no one's benefit, because that person will never come alive again. There are cases in which things have been done in which patients have been put on ventilators, but these are reversible conditions. This is not this irreversible condition in which you have blood all over the brain. There's no chance of ever getting back any brain activity. There's no blood flowing to the brain itself, and this person will not be able to breathe on their own. So a lot of times as we evaluate our stroke relatives and understand and see them in the hospital on ventilators and being able to breathe, and they're not moving their limbs or actually just some minimal amount of reflex activity, we should not have our hopes too high that they're breathing on a ventilator. We must establish whether or not that person has any capacity for carrying on life again as before, or even in a lesser state, but not in a persistent vegetative state. You must establish, is there brain activity, is there circulation to the brain, and assist the physicians by discussing it with your relatives. When is it that having a patient or a relative on a ventilator makes sense, or having them on a ventilator against their wishes when you know that that person will not have any future life ahead of them other than lying in a bed, maybe with a feeding tube, maybe with an IV line, with no expectation as to when that person is actually going to be, there's no chance of that person ever regaining a full life again. So at all times when we're assessing our relatives with stroke, lying in a hospital bed on a ventilator, be very clear in your mind what is the goal of the treatment, and if it is irreversible, to assist the physicians in trying to come to their own decisions rather than encumbering the process. Because taking a patient off a ventilator who is in a persistent vegetative state is just doing the favor to another patient who could probably has a reversible condition that will benefit from having that same ventilator being used. A few days ago, a 62-year-old gentleman presented to my office with a urinary catheter in situ and asking me to remove it. I asked him the question, why do you have a catheter, and what was the reason for having it in there? And he wasn't quite sure. A urinary catheter is instilled into a male via the urethra, through the prostate, the male urethra, through the prostate into the urinary bladder. The most common indication for a urinary catheter, which is a rubber tube that's inserted when we experience difficulty in urinating. The only way the urine can exit from the body in both males and females is via the urethra. In the case of the male penile urethra, it has to go through the penis and also into the prostate. The role of that catheter was to allow the gentleman to be able to pass urine. In the case subsequent to that, because of the insertion of the catheter, he developed a urinary tract infection. And we saw him for this urinary tract infection. We also removed the catheter from him, and he's able to pass urine frequently. But how does a urinary tract infection present in a male? In this gentleman's case, he had an infection of his prostate, which is one of the ways we could also get a urinary tract infection. We can get a urinary tract infection, which basically describes infection that goes in the urinary tract. In the male, the urinary tract involves the kidney, the ureter, the bladder, the prostate, and the penis. The basic fact and the most common cause of a urinary tract infection in a male is probably due to prostatitis, and infection spreads from the prostate through there. Also involving intercourse can also have infection that spreads through the urinary bladder, through the penis into the urinary bladder. In addition to that, we can also have obstructive uropathy, in which a stone blocks the exit of the kidney through the renal pelvis, and urine is not able to pass. The block-up of urine can become infected, and we can get a urinary tract infection. A urinary tract infection involving the kidney is much more dangerous than when it involves the bladder alone. This can cause pyelonephritis, which is inflammation involving the kidney and the ureter itself, and that can also spread into the blood. In the case of a urinary tract infection in the male, it presents with difficulty passing urine, painful urination, sometimes blood in the urine. Sometimes if it's spread outside of the bladder, it can cause fever and chills, rigors, and difficulty passing urine. The treatment of choice is, only treatment is to find out what is causing the urinary tract infection. It's to culture the urine. But if you wait for the results to come back within 48 to 72 hours, that patient was already going to have a urinary tract infection that spreads up into the ureter, into the kidneys, and now be having a pyelonephritis, which now has to be hospitalized for that condition. So empirically, we'll try and treat with what is the most common organism that's going to cause a urinary tract infection in the male, and be able to treat that, and then wait for the urine culture to come back. In the case of someone who presented with fevers and chill, is to get a blood count done, see what the white blood cell count is. If the white blood cell count is extremely high, we have to be much more vigilant in terms of treatment and finding out we have to go with the strongest antibiotic, whether it be Levaquin, ciprofloxacin, Augmentin, whichever one they're sensitive to. But it's empirical that you start treatment of it even before getting back to the culture report, and then alter your treatment or continue your treatment depending on what organisms. Usually it's a gram-negative organism, either E. coli, Klebsiella, that actually will be causing this kind of infection. In the female counterpart, having got the same kidneys, ureter, and bladder, those are the more common causes of a urinary tract infection, is obviously through the vagina. And basically much more common because the vagina itself, the urethra in the female is much shorter. It's also the close proximity to the rectum, and also because of sexual activity to the vagina, you can easily get an infection involving the bladder in a female. Very common to have, usually presenting with suprapubic pain, increased frequency of urination, sometimes passage of blood, sometimes difficulty passing urine, sometimes associated with vague sensation with the lower abdomen, with the increase in frequency of micturition passing urine. If the infection has not been treated properly or not been treated at all, you can also get an infection that spreads into the kidneys, resulting in pyelonephritis, which is basically involving the kidneys now and much more serious. So for all indications and purposes, a urinary tract infection in the female is most likely a bladder infection, and the treatment of choice is definitely to identify the most common organism, which is E. coli or any other gram-negative, and to start treatment immediately. Do the urine analysis and the urine culture, wait for the results to come back, evaluate your patient within 48 hours, and make sure that whatever antibiotic you've started the patient on, the prominent bacteria is sensitive to that. You must make sure, because we can have a partially treated urinary tract infection if we do not culture the urine and find out which bacteria, which antibiotic that bacteria is sensitive to. And that a partial treatment is just as bad, because a subclinical urinary tract infection can result in lots of complications even in pregnancy and outside of pregnancy. So the protocol of treatment, when you establish that in a clinical suspicion of a urinary tract infection, it's in both males and females, is to start treatment vigorously and rapidly, waiting for the urinalysis and urine culture to come back, and then alter your treatment of your antibiotic depending on what the sensitivity of the bacteria is. In response to a young patient of mine who asked me, "Doctor, can you explain to my father how people hear, because I feel he is getting deaf?" And how do we actually try and ascertain whether loved ones are getting deaf? It's basically very simple. They either turn on the TV much louder, either they want to ignore us, or basically they can't hear any longer. They tend to ask twice about something that's spoken to in a normal tone, and sometimes it may even seem as if they're ignoring you, whether by design or basically by accident, that they're not able to hear as well. And there's level of deafness due to threshold of deafness, whether low frequency deafness or high frequency deafness. But let's address deafness as a whole, and let's try to understand how deafness, dizziness, vertigo, and hearing loss can present in a single patient, and all because of the way the hearing mechanism is. If we look at the normal ear, the ear that enters, obviously hearing is all about transferring the sound impulse into electrical impulse that is interpreted by the brain, and then that becomes translated into the brain and makes sense of sound. Whether it be high frequency songs that come from contemporary music, low frequency songs come from people whispering, they all have to be translated to the brain in a learned memory fashion that basically makes you remember that you heard something like that, and that sound wave is translated as it passes through the auditory external acoustic meatus. It causes the tympanic membrane to vibrate. That sound is now amplified by the incus, by the malleus, then the incus, and the stapes, which are these three small bones that actually oscillate and increases the sound volume. then that sound wave, by pressing onto the stapes footplate covering the oval window, then translate that into monotones through the vibrating system, and then that is actually sent to the brain. This, when we look at this more when it's magnified, the song vibrations strike the eardrum. Through this, then it's translated through the malleus incustapes and then to the oval window, and then it goes through this cochlea. And basically, this is the part of the middle ear that actually, the inner ear, that controls balance when this movement is made. The eardrum itself is what separates an outer ear infection. The most common cause that we find in our elderly patients is evidence of we have to rule out whether or not there's impaction of a foreign body or wax into the ear itself that prevents the sound waves from coming to the tympanic membrane. In the child, more commonly, is the fact of having an ear infection, either a middle ear infection or an external ear infection that causes the tympanic membrane to be. The tympanic membrane can be damaged by a foreign body or from infection within the middle ear. Now, that pressure within the middle ear, the only way it can escape is via the tympanic membrane. We get a rupture of the tympanic membrane. Now, it doesn't oscillate as well. It doesn't transmit the sounds as well, and hence it results in deafness as well. There is difference between a neurologic deafness and deafness due to auditory deafness, and this basically is due to sound waves itself. So we can have deafness as early as it is in the auditory canal, or we can also have deafness due to the tympanic membrane. In cases in which the auditory ossicles are not able, the malleus, the incus, the stapes, are not able to vibrate and amplify the sound, especially because a lot of cases with us with high cholesterol levels, they actually fuse, or chronic ear infection, which occur here, can cause these to fuse, so there's no amplification of the sound, and we can result in deafness here. We can lose our sense of balance because here is where the cochlea, here is where the semicircular canals, which have levels of fluid within them, and movement of the oval window causes the fluid inside of the scala vestibula and the scala tympani to move. Those movements of fluid is what controls our balancing. If that is affected, whether due to an infection, what tends to happen is you move your head and you figure the room is moving as well. In a normal individual, the brain interprets movement of the head, the fluid level alters, but the brain transmits as saying the head is moved, not the room is moved. In a case of Meniere's disease, or in cases in which you have evidence of infection involving the semicircular canal, you get the sensation that you're moving, the ground is uneven. You also get the sensation that in addition to the deafness, you get the dizziness and the vertigo as if the room is spinning on itself. The patient would actually complain that they're lying flat on their beds and they seem as if the room is moving. That impulse now, this is where the semicircular canal controls movements, and the understanding of the brain to interpret movements of the room or movements of the environment does not mean, movements of the head doesn't mean the environment is moved. That impulse now is transmitted to the cochlear nerve, and then that's transmitted to the brain where it's interpreted. So deafness in itself, whether it be sensorineural deafness, which involves the nerve itself, which can involve the cochlear nerve, which is the one that actually makes us hear and takes the interpretation to the brain. Deafness in itself is not just a unifactorial thing, because we can see where it can occur from all the way down to the external ear. Anything that impacts on here, whether it be fluid, infection, or a foreign body, injury to the tympanic membrane, whether it be due to an infection or a foreign object, any cause that is, whether it be from swimming and chronic ear infections or high cholesterol that can cause the bones to fuse, to anything that can involve the tympanic nerve itself. We can also get deaf or fullness in the middle ear if the eustachian tube is blocked. In fact, how you hear is basically because the pressure on this side and this side is the same on the tympanic membrane. If this is actually blocked, then you get a sense of fullness within the middle ear based on a simple fact that you feel the pressure only on this side because there's a negative pressure in the eustachian tube. So the entire hearing mechanism, in response to this young lady who asked me, Doctor, can you explain to me why my dad is deaf? In one line, it was not that easy to explain to her that her dad was deaf because of the high cholesterol. that actually caused the fusion of the three bones that are supposed to actually amplify the sound. It was probably easier for me to explain to her that her dad had a lot of wax in his ear and we need to remove the wax to enhance his hearing. Yes, it did help with his hearing, but it did not correct his hearing. It was established that he had a deafness to a fair degree that he probably did not need to have a hearing aid at that stage yet. But definitely there was a decrease in hearing at that stage. And it was not a fact that he was ignoring his wife or ignoring his children. He had just managed to be getting deaf. Probably in our kids, the most common cause of deafness are infections. In our elderly, acoustic neuroma, which is also a tumor of the acoustic nerve, can also cause deafness. Within that scenario lies all the infective processes and the diseases, the common diseases that sometimes we suffer with, that can also cause deafness. So deafness in itself is not just a simple diagnosis of saying, oh, you can't hear, here's an hearing aid, or let me treat your ear infection, or let me remove your wax. It's a little bit more of a thought process than that.